So imagine you're injecting a tiny droplet of gel into someone's lip.
Right.
You're expecting this really subtle, beautiful plumping effect. But instead, within seconds, the skin around the injection site just turns stark, dead white.
Oh, yeah. That is terrifying.
It is. You are literally watching a blood vessel become blocked in real time.
Yeah.
The surrounding tissue is suddenly starving for oxygen. I mean,
Exactly.
this is the absolute nightmare scenario of facial aesthetics, right?
Yeah.
This condition called ischemia. And if it isn't reversed immediately, well, that tissue will literally die.
Yeah. It is without a doubt the absolute worst case physical complication in this entire field.
Just brutal.
And the crazy part is, it almost always stems from a singular, fundamental misunderstanding of what is actually happening underneath the skin.
Right, because usually when you look at an architectural blueprint, you have this expectation of absolute precision.
Oh, sure.
You look at the flat two-dimensional paper,
Yeah.
and you see exactly where the support beams are, where the electrical wiring runs.
Yeah.
And you could just point and say, well, there it is, that's the structure.
It's comforting.
It is. We want human anatomy to be that predictable.
Yeah.
But then, you step into the world of dermal fillers, and suddenly that 2D blueprint is just completely useless.
Completely.
Because we're looking at a biological landscape that is entirely three-dimensional, living, and just constantly shifting.
Yeah. Treating the human face like a flat textbook drawing isn't just outdated anymore. As the nightmare scenario shows, it is inherently dangerous.
Totally.
I mean, the face is the very definition of a structural labyrinth.
Which is exactly what we are exploring today. Welcome to this deep dive, everyone.
Glad to be here.
Our mission today is to give you, the listener, a shortcut to understanding the cutting-edge science of facial aesthetics. We've got a really fascinating stack of sources to unpack for you.
We really do. Some incredible data.
Yeah, we're pulling from clinical papers, from plastic and reconstructive surgery, high-resolution ultrasound investigations by prominent anatomists like Professor Sebastian Cortafana.
His work is just groundbreaking.
It really is. Plus, JAMA dermatology studies and advanced training guides from aesthetic academies. So we were going to decode why understanding the microscopic layers and planes in the face is the absolute key to safety.
Because what happens beneath the surface during a cosmetic tweak is, well, it's so much more complex than just filling in a wrinkle.
Right.
We are dealing with a highly vascular, multi-layered environment that demands immense respect from anyone holding a syringe.
So let's just start with one of the most popular aesthetic treatments on the planet, the lips.
Good place to start.
Because I think this perfectly illustrates the extreme danger of treating a 3D structure like a flat drawing. There's this study published in JAMA Dermatology by Dr. Murad Alam, and it looked at the rates of vascular occlusion.
Right, that nightmare blockage we just talked about.
Exactly. They looked at occlusion rates during lip filler treatments.
And the numbers in that study are genuinely sobering. They found an occlusion rate of 1 in every 6,000 milliliters of lip filler.
Wait, let me just pause and do the math on that for a second.
Go for it.
Because a standard syringe of filler is usually, what, 1 milliliter?
Yep, usually 1.
So that's 1 in 6,000 syringes. If a busy aesthetic clinic is seeing, say, 20 lip filler patients a day,
Yeah, which is very common.
that means they're rolling the dice on tissue necrosis multiple times a year.
Mm-hmm.
I mean, that doesn't sound rare at all when you look at the massive global volume of these procedures.
It's not rare. It's a very real number that practitioners face. But the study did highlight a massive caveat.
Okay, what is it?
That risk drops by a staggering 70% after an injector has 5 years of experience.
Wow, a 70% drop. That is literally the difference between life and death for that lip tissue.
It really is.
What magically happens at the 5-year mark? Do they just get steadier hands?
Well, no, it isn't just muscle memory or, steadier hands. It is the development of a high-resolution 3D mental image of the anatomy.
Okay, that makes sense.
Novice injectors often think in 2 dimensions. They look at the surface of the lip and they just aim for the shape they want to create.
Right, like painting on a canvas.
Exactly. But experienced practitioners, they stop looking at the surface entirely. They start seeing the lip as the 5-layer maze that it actually is.
Okay, let's visualize that maze for a second. Because for you listening, this is where it gets crazy.
Yeah, it's complex.
If I am a needle entering the lip from the outside in, what am I actually passing through? Walk me through the layers.
So first, you hit the dermis, which is the outer skin.
Right.
Immediately beneath that is a very delicate layer of hypodermic fat.
Okay, layer 2.
Then you plunge deeper and you enter the orbicularis oris. That's the primary sphincter muscle that allows your lips to pucker.
Got it.
Go even deeper past the muscle, and you find the submucosa, which is a loose connective tissue layer.
Yeah.
And then finally, layer 5, the mucosal layer.
And that's the wet part.
Yeah, that's the wet inside of your lip that rests right against your teeth.
5 distinct layers in a piece of tissue that is, what, only about a centimeter thick?
Roughly, yeah.
That is just wild to think about.
It is. And the most important part is that hidden within those layers is the superior labial artery.
The main blood supply to the upper lip.
Exactly. Now, Professor Sebastian Cotofana conducted this incredible study on 193 cadavers to map exactly where this artery hides.
And what did he find?
He found that 78% of the time, the artery is deep. It runs posterior to the muscle, tucked safely away near that submucosal layer.
Okay, so if I'm picturing this right, it's kind of like trying to avoid hitting a water pipe hidden deep behind the drywall of your house.
That's a great analogy. Yeah.
All right, like if you know the pipe is usually buried way in the back, you feel pretty safe hammering a nail to hang a picture frame on the surface.
Sure.
But our sources noted a really terrifying exception in Cotofana's data. In roughly 30% of cases, that artery changes planes within the exact same lip.
Yes. This is where it gets so dangerous. You could be injecting perfectly safely on the right side of the upper lip, knowing the artery is deep. But as you move to the left side of that same patient's lip, that artery has suddenly migrated superficially into a completely different layer.
Oh, wow.
Yeah, it weaves right through the muscle and sits dangerously close to the surface skin.
So the water pipe randomly moves into the middle of the room depending on which wall you're looking at.
Exactly.
But wait, let me push back on this. If we know this artery is highly unpredictable, why do so many practitioners commonly inject right at the vermilion border, the actual lip line, where we know the artery often weaves?
Well, unfortunately, that historical habit is completely based on aesthetic goals, and it completely ignores anatomical safety.
Ah, I see.
For years, practitioners just wanted to create a sharp, defined edge to the lip. So they would take a needle, enter horizontally along the vermilion border, and just slide it parallel to the lip line, squeezing out filler as they went.
Yikes. So they were essentially running a sharp needle horizontally down a blind tunnel that they knew contained a weaving artery.
Pretty much, yeah. Which explains those high occlusion rates we talked about earlier.
Definitely. But the sources do point to a massive shift in technique now, right?
Yeah.
This vertical submucosal approach. How does that physically work?
So instead of sliding a needle horizontally along that danger zone, innovative injectors now approach from a completely different angle.
Okay.
They often come vertically, sometimes starting all the way below the wet-dry border of the lip, and they target the deeper interlabial compartments.
Interesting.
They angle the needle upwards, essentially sneaking behind the typical pathway of the artery rather than running parallel alongside it.
This makes it painfully clear why an anatomical assessment before something like a labial puff procedure is just completely non-negotiable.
Oh, absolutely.
I mean, for you listening, if you are getting a labial puff, the goal is to create significant central volume in the lip. You just cannot guess where the artery is hiding when you're adding that much volume.
You absolutely cannot guess, because if you are doing a labial puff, you are pushing a large volume of gel into a very confined space. Even if you don't pierce the artery directly with the needle, depositing too much filler in the wrong layer can simply crush the artery from the outside.
Oh, just from the sheer pressure of the gel.
Exactly. And that causes the exact same ischemia. The tissue still starves.
Wow. But, this unpredictable depth of arteries, it isn't just a lip problem. If the lip is a localized maze, the whole face must be a labyrinth.
It really is a face-wide phenomenon, and this brings us to a crucial anatomical concept for safety coined by Professor Cotofana. He calls it the hide-and-seek principle.
Hide and seek, I like that.
Yeah, the entire face is layered. It's usually categorized into 5 main structural layers, much like the lip.
Yeah.
But the major blood vessels don't just stay in one layer. They weave in and out, changing their depth depending on which facial zone they are traveling through. So the injector literally must play hide-and-seek with the vasculature.
Okay, so let's track this. In the lips, the artery is usually deep, maybe layer 4 or 5. So injecting superficially in layer 2 is generally safer. But the sources note that as soon as you move down to the jawline, the The rule completely flips.
It does. At the jawline, the facial artery travels in the deep supraperiosteal plane.
Which means...
That means it is hugging right against the bone.
Oh, wow.
Therefore, if you want to enhance the jawline safely, you should focus your filler in the superficial fatty layer. You stay high because the artery is low.
Right. But then it flips again at the nose.
Yes, it does.
At the nose, the arteries travel superficially, meaning treatments have to be conducted in the deep plane.
Exactly.
And then you have the temples. The sources note that major vessels, like the middle temporal artery, run superficially there. So temple filler has to be placed deep, like in the interfacial plane or the deep supraperiosteal plane.
And, we cannot overstate the danger in the temple region.
Yeah, that area seems terrifying.
A catastrophic mistake. There isn't just a visible lump or a small patch of dead skin on the cheek. The vascular network in the temple connects directly to vessels that supply the eye and the brain.
Oh my God.
Yeah, an occlusion here can literally lead to blindness or severe vascular compromise in the brain.
I have to challenge the practicality of all this, though,
Yeah.
because to me, this sounds like a high-stakes game of anatomical whack-a-mole.
It really does.
How can any practitioner keep this straight?
Hmm.
Every single facial zone has completely opposite rules. Superficial here, deep there, superficial again. It's madness.
It is incredibly demanding, which circles right back to why that 70% risk reduction takes 5 full years of practice.
Ah, right.
You cannot just memorize a cheat sheet that says, inject at 3 millimeters depth here.
Yeah, it's not a paint-by-numbers thing.
Exactly. You
Right,
have
yeah.
to understand why the anatomy behaves this way. You have to visualize the 3D map of how vessels dive under muscles to protect themselves near joints, and then how they rise to the surface to supply the skin.
That makes total sense. But, vascular death isn't the only way a 2D mindset ruins a face.
No, it's not.
If an artery is a hidden pipe, the ligaments are like hidden structural pillars. And this is where we see massive aesthetic disasters, particularly right under the eyes. The famous tear trough deformity.
Oh, the tear trough. It is perhaps the most misunderstood region in all of facial aesthetics.
Because it's that area where you get that deep, dark hollow under your eye that just makes you look exhausted all the time.
Exactly. And to a layperson, you look in the mirror, you see that dark hollow, and your brain just says, well, that's a pothole. It's empty. Just put some filler directly into the pothole and level it out.
Right. Just spackle it. But the sources explicitly warn that this is a structural illusion.
It is a multifactorial illusion. When you see that hollow, you aren't just seeing a simple loss of volume on the surface.
Okay, what am I actually seeing then?
First, you're seeing skeletal remodeling. The actual bone of the eye socket, the maxilla, it recedes and widens as we age.
The bone itself changes.
Yes. And second, you are seeing the descent of the deep medial cheek fat pads.
Let's clarify something about facial fat here, because I think a lot of people picture it like a smooth, continuous sheet of butter under the skin.
Right, like a layer of frosting.
Exactly. But it's actually compartmentalized, isn't it?
That is a vital distinction. Facial fat exists in distinct, separate pockets or pads, almost like a tiled mosaic.
Okay.
As we age, the connective tissue holding those tiles together weakens, and the fat pads literally slide down the face and separate from one another.
So the cheek fat pad just slides south, leaving a physical gap between it and the lower eyelid.
Yep.
And making matters worse, the sources highlight this severe tethering by true osteocutaneous ligaments.
Yeah.
Specifically the tear trough ligament and the orbicularis retaining ligament.
Yeah, these ligaments are dense fibrous bands that anchor the skin tightly to the bone. They act like internal ropes.
Internal ropes.
So as the bone recedes and the fat pad slides down, these ligaments hold fiercely onto the skin, pulling it inward and creating a very deep shadow.
It's like having a sagging camping tent. If the tent poles underneath are collapsing, you don't fix it by just throwing more heavy fabric on top of the tent.
Right.
Especially if there are ropes tying the fabric tightly to the ground. Throwing filler on top just creates awkward bulges around those ropes.
That is a perfect analogy. And if you do just, throw fabric on top by injecting filler superficially under the very thin skin of the under eye, you invite 2 very common, very frustrating complications.
Okay, what's the first one?
First is the Tyndall effect.
I've heard of that. That's a bluish discoloration, right? But why is it turned blue?
It's basically an optical trick. Because of how light scatters through the exceptionally thin skin of the lower eyelid, it hits the clear particulate gel of the hyaluronic acid filler.
Oh, I'm saying.
And then it reflects back as a bluish hue. It looks like a permanent glowing bruise.
That sounds awful. And what's the second complication?
The second is persistent foggy edema,
Mm.
basically chronic puffiness.
And the sources point out this is due to the chemical nature of the filler itself, right? Hyaluronic acid is hydrophilic, meaning it acts like a sponge.
It loves water. It attracts and binds to moisture in the surrounding tissue.
Okay.
If you place a hydrophilic sponge superficially in the under eye area, which already has incredibly delicate lymphatic drainage, that sponge is just going to hoard fluid.
Oh, so it just swells up.
Exactly.
Yeah.
You will wake up every morning with puffy eyes for months, sometimes years, because the filler is actively trapping water right under the surface.
Wow. So if pulling that sponge closer to the surface is a recipe for permanent puffiness and blue shadows, logic tells me you have to go deep.
You do.
You have to bury it to rebuild the temples.
That is the anatomy-led indirect approach. Instead of superficially filling the shadow, practitioners place a deep supraperiosteal bolus of filler.
So right on the bone.
They put a precise drop of gel right on the bone, completely under the muscle. They're essentially rebuilding the structural support of the maxilla and lifting the entire deep medial cheek fat pad back up.
That's fascinating.
Yeah, you lift the shadow from below, rather than just painting over it from above.
So we've mapped out these hidden arteries flipping between layers, and these structural illusions caused by sliding fat pads and tethering ligaments. The obvious question is, how do modern practitioners physically navigate this biological minefield safely?
Good question.
Let's look at the tools of the trade. First up, needles versus cannulas.
This is a fierce debate in the aesthetic community. A traditional hypodermic needle is sharp. It requires very little force to pierce tissue.
Right.
Unfortunately, that means it also requires almost zero force to effortlessly slice through the wall of a blood vessel.
Thus creating the occlusion nightmare we started this whole conversation with.
Exactly why many practitioners in high-risk danger zones prefer blunt-tipped microcannulas. Because the tip is rounded and blunt, rather than sharply beveled, it requires more force to move through tissue. When a blunt cannula encounters a blood vessel, it tends to just push the vessel out of the way.
Oh, so it gently rolls past it rather than slicing it open.
Precisely.
That makes total sense intuitively. But the sources provide a really fascinating caveat about physics here. A cannula is not a magic wand.
No, it is not.
If you use a really thin cannula, like a 27 gauge, or if the injector just pushes with too much brute force, that blunt tip can absolutely still perforate an arterial wall.
It comes down to force over area. A thicker 25-gauge cannula has a wider blunt tip, so it spreads out the pressure and easily nudges vessels aside.
Right.
But a thinner 27-gauge cannula has a much smaller surface area at the tip. If you apply enough force to a tiny surface area, it stops acting like a blunt instrument and starts acting like a dull spear.
Wow.
It will just punch right through the artery.
So if a properly sized blunt cannula pushes vessels out of the way and provides all this gliding safety, why isn't everyone just using cannulas for every single procedure?
Whoa.
Like, why would an injector ever actively choose to use a dangerous, sharp needle?
Because of the tent poles. Remember the terror trough?
Oh, right. Rebuilding the structure.
Exactly. A cannula is fantastic for threading product smoothly, horizontally through a superficial fat layer. But when you need to place a highly precise, deep bolus of filler directly onto the bone to rebuild structure, a cannula is just too flexible and clumsy.
It bends too much.
Right. A sharp needle allows the injector to go straight down, vertically through the layers, hitting the periosteum with pinpoint accuracy without displacing all the surrounding tissue.
So it's a constant trade-off between precision and gliding safety.
Always.
But there's another tool mentioned in the sources that feels completely revolutionary for removing this guesswork entirely. High-frequency ultrasound.
High-frequency ultrasound, or USG, is changing everything. We've talked extensively about how unpredictable the anatomy is, you know, the 30% of labial arteries that change planes, the flipping depths of the facial arteries.
Right.
Ultrasound allows the practitioner to literally see beneath the skin, mapping the exact depth and location of vessels in real time before a needle ever touches the patient.
The sources gave a brilliant example of this with the angular artery, which runs near the nose. Ultrasound studies showed its average diameter is about 1.4 millimeters.
Very small.
Right. But more importantly, it proved that textbook depths are useless because the depth of that artery is heavily influenced by a patient's biological sex and their body mass index.
Absolutely. If a male patient with a higher BMI sits in the chair, his soft tissue thickness is completely different from a female patient with a lower BMI.
Makes sense.
The angular artery could be sitting millimeters deeper or shallower. It is bespoke anatomy.
Bespoke anatomy. I love that phrase.
Ultrasound lets the injector see exactly where that 1.4 millimeter vessel is hiding in that specific person on that specific day.
It's incredible technology.
Yeah.
But even with all these tools, cannulas, needles, real-time ultrasound mapping, the training guides emphasize that safety protocols are still the ultimate fail-safe.
Because technology is useless without technique. The primary safety mandate is slow injection speed. When you inject slowly, you introduce less volume at once, keeping the extrusion pressure low.
Okay, why is low pressure so important?
If you happen to be dangerously close to a vessel, low pressure prevents a massive, severe embolus from shooting into the artery.
And if the worst-case scenario does happen, if the skin blanches white, there's an emergency undo button.
Yes, hyaluronidase. It is an enzyme that immediately dissolves hyaluronic acid filler.
Thank goodness for that.
Every single injector must have this immediately drawn up and available. If an occlusion occurs, they must flood the area with this enzyme to melt the filler blockage and restore blood flow before the tissue dies.
So let's bring this full circle. We've navigated the five-layer maze of the lip, the hide-and-seek vasculature of the jawline and temples,
Right.
the structural illusions of sliding fat pads in the tear trough, and the physics of the cannulas and ultrasound used to map it all.
It's a lot to take in, but the overarching lesson from all these sources is that human anatomy is not static.
Definitely not.
It is a living, breathing 3D architecture that varies wildly by person, by gender, by BMI, and by the natural remodeling of our bones. Respecting that microscopic complexity is the absolute baseline for aesthetic safety.
For you listening, the next time you look in the mirror, take a moment to truly appreciate that incredible machinery. You aren't just looking at a flat surface. You are looking at an incredibly complex, layered, dynamic system operating just millimeters beneath your skin.
It really is a marvel of biology, one that requires intense study to manipulate safely.
But I want to leave you with one final provocative thought. We learned from the ultrasound data that the angular artery doesn't just vary by BMI. It actually shrinks in diameter by roughly 0.01 millimeters every single year as we age.
Yeah, the vessels themselves are changing over time.
So if our vascular pathways are constantly shrinking, shifting, and physically remodeling over our entire lifespan, well, could the safe injection zones of today slowly morph into the highly dangerous occlusion zones of our future selves?
It's a scary thought.
The blueprint isn't just 3D. It's a moving target across time. So the next time you think about fixing a structural pothole, remember, you might just need to check where the water pipes have moved to first. Thank you for joining us on this deep dive.